Well, hello and welcome to the 27th Degree with Chris and Nancy, being broadcast from the BioSkills of the Northeast studio in Fall River, Massachusetts. Today we'll be discussing physical therapy with Cristen Sirois. Before we begin our conversation, I'd like to thank our sponsors, BayCoast Bank. BayCoast Bank is just right for all of your financial needs. Visit baycoast.bank or call 508-678-7641 to learn more. And Duncan Hearing Healthcare you can trust, with sites in Fall River, Dartmouth, Falmouth, and Centerville. For more information, visit their website, duncanhearing.com. As always, you can support the 27th Degree with Chris and Nancy by subscribing to us on YouTube or your favorite podcast platforms, and by following us on Facebook and Instagram. Also, please remember to leave a review, and 5-star reviews, of course, are always appreciated. So, Cristen, can you tell us a little bit about yourself? We'll start with that. Just share with the audience a little bit about your background, and we'll go from there.
Certainly. Thank you very much. I'd like to say thank you for having me on. My name is Cristen Sirois, and I'm a physical therapist. I've been a physical therapist for almost 29 years. I graduated from Quinnipiac College. It's now Quinnipiac University, but my time, it was Quinnipiac College. I was very fortunate that when I was graduating, we were kind of in high demand. So I actually got a job before I graduated because Morton Hospital needed physical therapists. So they paid for a couple of my semesters. So I, in turn, had to work for them for a couple of years. So while I was at Morton, which was my first job, I had the pleasure, and I did just about everything that they offered. So I started with acute care. I did some TCU for them. That was when they used to have those transitional care before you, went to the SNF. So hopefully you would go there first. I did outpatients for them. Was in charge of the aquatic therapy program. I helped run the prenatal program that we had. And so I got I had a little bit of everything that Morton had to offer. So it was very nice. From there, I pretty much went into home care, which I've been doing home care for the last 21 years. I am currently with the South Coast Health at Home, and I've been there for almost 16 years. Great. And then the other 5 years, I had worked at different agencies where I went to adult day healths, group homes, a little bit of traveling, kind of all over the place. Right. So, like I said, I've been very lucky that I got a little bit of, a lot of things. My favorite, or my high interest levels would be orthopedics, vestibular therapy, and wound care as far as specialties. But, we really kind of touch upon a lot of things, especially with home care. You're in there by yourself, and, you go in for one thing, and sometimes it's not anything to do with what you're there for. So
you've seen a lot from the hospital side now to what you've been doing most recently, more the outpatient side of things in the home with home care. So it's a big, I guess, variety.
Yes,
you've experienced. So what do you like most about doing what you do in the home care setting?
I actually like many things about it, but I feel like we become, especially physical therapists, they say physical therapy and people think that you're just doing exercise and you're just walking, or you're just doing
exactly.
But in particular with home care, sometimes only PT is ordered from the hospital, whether someone's had a heart surgery, a gastro surgery, a knee. It can be the whole gamut, and only therapy's been ordered when they come home. So when I go in the house, my job doesn't just fall for therapy. I have to do a full med review, and then I have to go over their discharge instructions. And if they have a wound, I need to take a look at the wound. And then, after usually a lot of other stuff, then the actual physical therapy part comes. I actually enjoy a lot with, getting to know people, kind of getting their social setting, making sure they're safe. They have all the equipment they need. And usually my biggest priority is, is somebody watching this person? Are they not by themselves? Even if they're living by themselves, do they have someone, to care for them? And, that's a big priority, I feel, for me, but also with us professionals as home care professionals, that, that's a big thing nowadays, because people aren't always honest, and people want to go home from the hospital and they're afraid you're going to stick them in a nursing home. And people will say, oh, my daughter's a nurse and she does my meds, but the daughter lives in New Hampshire and comes down every 3 months. So she's not doing the meds.
Exactly.
I mean, so there's a little missing part. So we kind of are the detectives. We kind of have to,
that's great.
Pull things out of people.
I mean, there's a lot you can get from doing a home visit more than you can.
I was just going to say, so we're there.
So why not?
I think one of my not favorite times of COVID, but we were the eyes and ears for doctors because we never stopped working. So during COVID, offices were closed, but I did televisits and phone calls with doctors all the time. And can you do this? Can you tell me what you see? Can you, take their vitals and all that? So we've become a kind of the eyes and ears of what, you may not see in your practice, doctor, because, someone is like trying to look as good as they can because they don't want you to give them another pill or, send them for another referral or a test. So
you don't see how they're really living.
Yes, we get a true picture of people.
True, so true.
So, Cristen, a few things that you said surprised me because I think that a lot of people, like you said, just think it's like knees and hips, or arms. And, they don't realize that there's a whole other side to
like
you.
A medically complicated patient.
Yes.
Right?
Like what surprised me the most just listening to you talk right now was wound care. So can you talk a little bit about that? Like, what do you do with wounds?
Well, the biggest change for wounds for us, at least at home for physical therapy, is that for most of the patients, they only come home with physical therapy orders. So one would think that perhaps like that nursing would be in on it because they come in home after surgery and whatnot. But the protocol right now is that the therapists do the admissions, and part of that is us evaluating, the wounds. Most of the patients come home with non-removable dressings that are supposed to stay in place 7 days. Some of the doctors like them a little longer. So initially when they come home, we're just assessing the dressing, the integrity of the dressing, how much drainage. We do carry, wound care supplies and dressings, so we are capable of changing dressings. They usually don't like you to change them unless they're 70% or more saturated. So it's kind of our judgment call. And some of the doctors want a phone call first before you do it, even though they're going to let you. They just want to know what you see. And some of them say, oh, no, we want to take a look because it's so fresh because, orthopedics has changed so much. So we get to do all that kind of stuff. We've recently been actually trained to take out staples. Wow. So we've done some of that, which is something also new because that's not usually like in our typical scale of things. Right. But we do. Some of us are trained to take out the staples, so we can take staples out from wounds. If we are following wound care orders, we have to always check with the doctor just to make sure, and if we think that something would be better, we call the doctor and ask them, they came home with, this recommendation, but we're seeing this. Do you want to change it to something else? And, though we're doing a lot more with wound care and stuff, if there's anything that I think it's infected, I'm just speaking for myself. If it looks infected, if something doesn't look right, I'm all about calling for help, and I'll ask is the doctor, can I have one of our nurses come and take a look at this? This is what I see, but I'm not sure what exactly we should do for it. So, it's really becomes a team approach, but, sometimes we are alone, and most of the time with orthopedics, it's kind of us, doing what we need to do.
So when you're saying wounds, you're talking more about surgical wounds, not necessarily like a pressure ulcer or something of that nature. Because I would think there'd be a nurse involved if there's a pressure.
If we find them, doctor, we do get.
You find them, right?
But we do a lot of identifying and then trying to stage them. So if we see something, if I am a subscriber that a lot about a lot of things, but. That's something that if I am seeing something opening, whether it's on the backside, on under the heels or something like that, certainly I want somebody else to take a look at it. And I don't know all of the dressings, and all of the ointments, and should we use Vaseline versus cream? So when it comes to like pressure ulcers and stuff like that, we do much more identifying, and calling someone in versus us actually, addressing that.
Got it. Okay. Yeah.
But I like laser wound care is something that I love. I've gone to several courses and was certified. So I love to, look at wounds and I'm very, I like to go with the nurse too, because I feel like it's something that I could, of course, benefit from too by looking at it.
So you're like the gatekeeper at all the good stuff.
Yeah. You get you're really kind of the eyes and the ears and sometimes the first one to see what's going on in the home.
Yes.
Yeah. It's interesting because I always thought, simple orthopedic procedures. I know that there's not always a nurse, but I would think that some of these more complicated patients, there would be a nurse involved. But you're saying sometimes
it's not. If it's a planned, just joint replacement,
Yeah,
a lot of times it's just us doing the admissions,
that makes sense.
Sometimes if it's a more complex patient, medically, they have
Then
more,
you would have a
they
nurse.
might have a nurse come in, or they had, a lot of times the nurses will be in if it's a patient that got an infection
Okay.
in their wound, or, they had a replacement and they had an infection, or some of the Boston doctors still prefer the nurses to come in before us, just
Okay.
to do a visit or two just to make sure.
Yeah.
So, sometimes it's dependent on who's ordering, the home care and whatnot. So, but any of us, the physical therapists, the speech therapists, any of us that are doing an actual admission to home care, we can order whatever is needed. So if I go in and, someone is just supposed to be a straightforward, knee, and there's some problem, or they look at me and say, I don't know how to take any of my meds, or, can you tell me this? There is just, I only know so much. So if it's out of my scope, I will have no trouble. I'm going to have to ask the nurse to come in for a visit or two.
Okay, makes sense.
It's, the people I work with are great about that, pulling each other in, we don't mind. And I know if I had a question right then and there, I could call someone to ask.
What's nice too about having a physical therapist on a case with you is sometimes, like a lot of times with the patients that I see, you're only in there once a week. So, initially when you start, you may have, you may be seeing them more than me. So, over that initial period, like if I'm in and doing an admission, then I'm not coming back for 7 days, but you're coming back at the end of the week. You're catching something that might need tweaking before I get back there. And that's huge.
Makes sense. And I've gotten a lot of calls from physical therapists at home. Blood pressure's high.
Yeah.
It's interesting. So now I understand more that you're doing more than just therapy with patients.
Yeah, it isn't. And, sometimes I have to be honest, my visit is 10 minutes of therapy and 35 minutes of meds or medical stuff, or sometimes psychosocial stuff. So especially in the home, they always say that we're kind of a unique entity, because it's not just your one profession. You really have to, you can't have that, I'm just the physical therapist, because some days you have to play more of a role. And that's just the way I think
Makes sense.
healthcare is going too.
Because in the hospital, you have more access to, say, nurses or, physicians are there in the hospital, and you might be the only one in that providing services for that patient in the home. So
yeah, it's more carved out in hospital. It's like more definitive per specialty. But like when you're in the home and you're seeing their true functional state and what they're good at or what they're not good at, I mean, again, you're like the gatekeeper to their health,
Yeah,
But
that's right.
Kristen, you talked about the simple referral process when someone's in the hospital and it's just like the nice transition to home.
And
What happens like if you have someone in the home who's decompensating that you think might be a candidate for physical therapy? Do you just call and like an agency and say, can I have a physical therapy eval, or is that something?
I mean, if I'm a physician and I have a patient who is,
Well, just like me, like my mother-in-law lives with me. So if I see her not moving around as good and I'm like, geez, I think she could, or if I see her struggling when she's doing stairs or something and I'm thinking in my mind, we need to just have like a home eval, a safety eval. Does she need like adaptive equipment? Like I just want a physical therapist in the home. Like how do I get that to happen?
well, you can answer this, but when your physician would generally, or
Yeah, I was just going to say the doctor has to.
PA physician has to order it, and there's supposed to be, with Medicare at least, a face-to-face evaluation, so which makes it complicated. So if you have someone that's at home who can't get into the office, that can be a challenge. So you're either doing a televisit, or if you have a service like Primacare has, where we have nurse practitioners that go into the home and do visits on homebound patients, you can do that visit in that way.
Okay.
You usually have to, like, because some patients come home from the hospital and they haven't seen their doctor in years. And I believe, Josh, you can correct me if I'm wrong, I think it's 30 days you have to see your doctor for Medicare to cover us.
Yeah.
They have to see. So if I was to see someone starting today, they need to see their doctor. If they haven't seen the doctor 90 days prior, that they need to see them within the 30 days of initiating home care.
Oh,
Otherwise, we have to discharge them after the 30 days.
So they definitely have to be seen. So it becomes a challenge with some patients.
So you just threw kind of an interesting word out. You were talking about homebound status.
Yeah.
For inpatient, like in-home therapy, is that a criteria they have to fall under? Like, is that the difference between having physical therapy at home and going outpatient for physical therapy?
Yes, with Medicare, and Medicare sets the bar. Not everybody has Medicare, but Medicare tends to set the bar, and everybody kind of falls underneath. With homebound status, for someone to qualify for home care,
Yeah.
it's got to be a taxing and hard event for them to leave the house. Now, that being said, they are allowed under Medicare to get their hair cut, to go to church, to pick up their prescriptions, and go to doctor's appointments.
Yeah.
That all falls under that. It's not shopping, no casinos. I'm just lightening the mood a little because I've gotten that before. Sometimes some of these people, they're really cute and they're just like, well, yeah, but if you come, then there's one less appointment I have to go to. It makes you smile. But I'm like, well, I understand that. I said, but the reason I get to come here is because you can't get out. Like it's too hard. It's too trying. It's not safe.
Right.
It's not just because there's one less appointment. Sometimes, and I have to be
very
honest.
specific.
Yeah. And sometimes patients, even if they need us, they don't want to be stuck at home. Like even if they're the most unsafe person I'm watching, I'm like, oh, sitting there like this, they don't want to be stuck at home. Yeah, I'm not going to stay home. So if they're not going to stay home, ethically and medically, and, we work under licenses. I can't say this person's staying home and they're off at Kohl's or shopping or something. So if that's their choice, we have to call the doctor and we'll just be like, we appreciate the referral. And, I saw Mr. So-and-so. I tried to convince them, but, they really don't want to stay home. So in that case, I will usually try to talk the patient to going to outpatient therapy.
Right.
How about you you really could benefit from some balance work or some strengthening. So how about I ask your doctor if they'll send you to outpatients? Some of them will go, and some of them, no. You know what I mean? That doesn't interest them. So
Well, that brings up a good question. Are you able to do physical therapy at the same level in the home than you would do in an outpatient center where there's equipment available, et cetera?
I giggle and say we should have U-Hauls, but we don't. So there's only so much that we can do in the house. And our primary focus when we do go in the house, whether someone's been in the hospital or rehab or it's just a doctor's office referral because they've kind of, to your point, Nance, digressed a little bit, having some trouble at home. Our first priority is, can they get in and out of bed? Can they do the stairs if they have stairs? Can they transfer safely? Are they walking okay? Is the house set up as safe as they can be? Along with that, we do exercises. I carry myself weights, some bands, pictures, so that I can leave all that stuff for someone. Some of them have those little bikes that we, work with them.
Yeah.
Some of them have treadmills and we work on a walking program. As far as the if it's weather and they don't mind, it's good. I don't care winter, spring, or fall. I dress accordingly. So I'll take people outside, and work on their walking and try to help them establish a program with that. But they do, we do reach a point where we're not, especially with people like the orthopedics and certain populations, we do reach a point where we're not able to, take them any further than they need to be. And if they're agreeable and want to benefit from that, then that's the perfect opportunity, because when someone goes to outpatients, to your point, doctor, they have more equipment than us. And, it can be a little bit more strenuous and getting them into a little bit more shape. And especially if someone wants to transition back to a gym or a YMCA or a Boys and Girls Club, it's an excellent transition, the home care to outpatients and then perhaps back to their own workout, whether it's a gym or even at home.
Cristen, I remember vaguely, because my memory is going. I remember when I used to work in the hospital and we had, someone that was in bed for a couple of days. It was kind of like a rule of thumb, for, if you're kind of confined to the bed for a day, it means 3 days of, working to get back to where your baseline was.
Quite a bit of muscle.
Yeah. So can you just talk a little bit about how quickly someone can decompensate when they're in a bed? Yeah.
Yeah, they really do. I think that I want to I've read somewhere that 3 days in bed equates to 30% of muscle loss.
Yeah.
So you can just imagine that just multiplies,
Right.
the longer that they're in bed. And unfortunately, with the way that healthcare is nowadays, we get people they order physical therapy at home and they've never been out of bed at the hospital.
Oh.
So so we're not getting sometimes a good sense of where this person is until we actually see them.
Right.
And it's just because I think the turnaround and, the observation statuses and, someone it's in, get them in and get them out. As soon as they're stable, there's not time to get a therapist in there to get them up and give you an idea of, yeah, this person will benefit from this person will benefit from that. But, when we go even in their houses, one of my first things that I always go over with people, like a broken record, is every hour you need to change position. I don't care if you just stand up, take a deep breath. It might be a bathroom trip, and I usually go like this because that's me, a bathroom trip. But, it might be a little walk. It might be you go lay down. Then you go, when you're waking hours, you need to move every hour. When you're sleeping, we let the sleeping patient sleep. But when you're awake, you need to move. And moving builds strength and it builds endurance. And I always tell them that they need to focus on the little things because, I'd rather them do 3 or 4 little walks where it's just a lap around the house,
Right.
them get up and do 10 laps and then they're wiped for the rest of the day. They have no energy. So the only way that they're going to build endurance, and the same thing in the hospital, is lots of little things. And sometimes you can get people, especially if they're not exercisers, to buy into it.
Right.
If you don't give them a book or you don't give them an hour's worth of things to do. Say, hey, this is only going to take you 5 minutes, but you're going to notice a difference.
Right.
Be overwhelmed if you give them too much, I would guess.
And then sometimes too, you kind of have to, it's just like I think when we're younger, we have kids or not kids, or you play that game of, well, what are your goals? Well, if you want to go in the yard, you have to get moving. I mean, I know you're not an exerciser, but you got to start doing some stuff if you want to get your gardening. So, you have to, whether you're in the hospital, the home care, whatever setting you're in, you really have to kind of hone in on who you're working with and what motivates them. Because if they're not motivated, you're not getting anything.
That's their goals. Everyone has different goals.
Yep. And sometimes what I think my goals are for them is not necessarily what their goals are. So we have to talk.
That's such a great strategy. I mean, even after PT leaves your home and is not coming back, just for the family, for motivation, because sometimes we don't know how to approach it with our loved one who might be living with us. It's like, come on, you know what the therapist said, you got to go out there, you have to do this, but it's more like incorporating their goals, because then it's become self-motivating.
Yeah. And you have to be like, well, if you want to do this, you've got to do this. But we all know in all levels that they do more for strangers than they do for our families. I always
You're on that.
because I feel like sometimes people, families will sit there and they'll be shaking their heads or saying something while the patient's telling me something, and I'm laughing because, of course, I've been doing this for a while, so I know, they're telling me exactly what I want to hear. But everybody is so afraid that I'm going to go in and say, yep, you're not safe at home. Out you go. That's it. You can't stay home. So they're on their best behavior, and the family's like, they don't do this. They don't do it. Like, I know. They're just being on their best behavior because I'm here.
Yeah.
I get it. So but again, it's trying to get people to buy into it. And some people, you have to kind of be creative, because you hand them a piece of paper, the paper's a coaster. I could give you a book of exercise, head to toe, soup to nuts, and it takes you an hour, and people are blinking at you, oh, I'll do it. And you're like, so, it's definitely more productive and more conducive if you hand someone, takes them 5 minutes to do it. And that they can, then I can argue with them. Don't tell me you don't have 5 minutes.
Right.
This is only 5 minutes. You could do that in a commercial break. Would be a favorite soap opera.
That's true.
You could do it in a commercial break.
Telenovela.
You know what I mean? So, you kind of, it is all about trying to motivate and trying to finagle. It's not just, you can't usually come in straightforward.
Right. It's funny that you say that, because I've been in patients' homes when the therapist has shown up, and the therapist will leave and they'll turn to me and they'll be like, did I pass? How did I do? And I'm like, you're okay. As long as you were truthful, you're good. You're good.
Yeah.
You're good.
Exactly. And, don't get me wrong, not everybody's happy to see me. I thought that more people are not happy to see me than are.
Yeah. Yeah.
Yeah, you got to have a little thick skin. So,
Do you think it's easier to get people to succeed kind of in the acute phase, or to maintain, especially the elderly population?
I think if people have support, it's easier to get them to maintain. Yeah. And also, if they truly have something that they want to be able to do, especially the elderly, like a big thing with them is they want to be able to drive. And driving is not just being able to go sit in the car and drive. If they have stairs, they have to be able to get out the stairs. Do they have a cane? Do they have a walker? There's a lot of steps that kind of get to them being able to do something like that. And nowadays, it's kind of nice with all one thing that we did get from COVID is you can drive anywhere and people will just put things in your car. So you don't, the big thing for them is just, can they drive somewhere to get something? So that seems to be a big goal. But there's a lot of steps for that. So if someone lives on a second floor, when we would come in and someone's telling me that they'd really like to be able to drive and they're great on their floor, but now they've got a walker. How are they going to get the walker down 2 flights of stairs to get to the so, maybe we get them another walker because, so they have a walker already at the bottom of the stairs. So there's one downstairs, there's one upstairs. So now if you can get down the stairs with the railing, your walker's there, then you can get to your car. So there's sometimes it's a more than one step process for somebody's goal, but things can be done, but those are motivating factors. And then you have to say, hey, if you think you're going to be able to do the stairs, you got to keep exercising so you're strong enough to do the stairs, get in your car, and get out of here. You know what I mean? And for some people that works, but not everybody does. That it's not for everybody. But if you can kind of capture and work with people around what their goal is, sometimes you can get them to keep up with maintenance. Not everybody, but some of them. And then, of course, we have a lot of repeat offenders, I call them sometimes, where people we see several times a year because, whether they just decline or unfortunately they get rehospitalized for whatever reason, so we get to go back in. But
why are you looking at me when she says people decline?
No, I'm just saying if you got a question, that's all.
Oh, I do, as a matter of fact.
I know. I don't want to interrupt you. That's all.
Just making sure you didn't think I was in decline over here.
No, I did not say that.
So
I would
Cristen,
never.
When you walk into a house, like, what are red flags to you? What are kind of some things that you look at and you're like cringeworthy? Like you're like, oh man, there's like 20 throw rugs in here or whatever.
Yeah, throw rugs would be one. Most of the time it's obstacles and boxes. Sometimes the doctors will order, it's just a doctor's office referral. The patient has reported that they're not walking well at home and you walk in and they have a walker, but there's no room for a walker, so you're like, oh boy, and then trying to get people to clear, to agree to, well, can we just move this a little bit over here or a little bit over there? That a big thing for me is, but I think it's just because that's how I am at home too, is cleanliness. Are they able to be, is this house, is it safe? Because, we all know if it's filthy or, that can cause respiratory problems. It can cause breakdown. It can cause, a lot of stuff like that. Another thing when I go in is, they'll tell you, oh, I'm fine, but they're sitting in, I call it the throne, their recliner, and there's TV trays everywhere. So there's food, there's medicine, they don't have to move, CPAP machine. There might be, the TV controller. So that person is not moving much. So when they're telling me, oh, I do all my own stuff and not, maybe, but it doesn't give that vibe that, hey, this person's moving around a lot and they can take care of themselves. Another big one is smell. As soon as you walk in the door, you can tell, if someone's incontinent or not incontinent. So are they able to wash themselves up? Are they, you know what I mean? Are they clean? Do they have skin breakdown? So even, before I start with someone, it's funny, but our senses kind of just, there's a lot of things that go up on areas that, and what I mentioned, notice not one thing was exercise and are we walking? Like I haven't even gotten to that yet. It's just the general appearance of the house and what it is. Already I know that there's a possibility that we could have skin breakdown, incontinence, problems with eating. Are they taking their meds? That's
so many things.
So
all that impacts on their ability to rehabilitate, recover.
Absolutely.
Yeah.
And that's how sometimes it's like I said, my job is this much therapy at first and this much of everything else because you got to get, it's everything in line.
Primacare is Southeastern New England's trusted leader in medical care. With offices in Fall River and surrounding communities, we're dedicated to your well-being. Our carefully selected team of more than 150 providers offers world-class primary and specialty medical care. Primacare doctors are supported by a skilled staff trained to deliver comprehensive radiology, imaging, and testing services. Primacare is large enough to take care of all your medical needs, but small enough to care for you personally. Primacare is by your side.
I remember too, like we have a lot of elderly in our community that does live alone. And, when you go visit your mom or your dad or whoever, you're seeing a snapshot of them. And a lot of times it's the picture that they want you to see. But then, you go in an off time. I remember my mom was in going between a walker and a wheelchair to do her laundry. I came in one day at a time. I didn't usually go in there. She had gotten a rope, tied it to a walker, and was dragging her laundry basket behind her as she was like very creative,
Creative, but
But I think sometimes, it'd be very beneficial to cue into things they may need before they actually need them. And I think as Chris gets older and older every minute,
Thanks.
one thing
by
the second millisecond, he may want to be thinking about how do you age gracefully in home. Can you talk just a little bit about common things that are needed, like maybe grab bars or what have you, and things to think about as we like to think we can stay in our house, and what we should be thinking about now in our 50s or 60s to set us up for our 70s and 80s?
That's a very, very big thing now for people, even that are cognitive and not cognitive. We all think we're going to live forever. We all like our houses with stairs and different levels and uneven things and thick throw rugs, little throw rugs, all kind of stuff like that. And until something happens, and then until, you're kind of hit with it. And then
Right.
I don't want to say that it's too late. It's just you're behind when that happens. It's very hard for especially people who have had the same rug in the same spot for 50 years. And then I come in and say, well, you've had such an easier time getting to the toilet. If we got rid of the 3-inch shag rug that's underneath the toilet. Oh, but my feet are cold. I'm like, I know, but we could get maybe a smaller one that's got some rubber under it and it's not going to move, and then you're not right on the tile. We have those kind of discussions a lot, but I encourage people, because we talk to families too, and sometimes families don't realize that, like our age people, we're looking at our parents, and then, the therapist is telling the parents, well, we need to get a grab bar, and you really should have a walk-in shower, and you should have this. And then family members will kind of be looking at me, and I'm like, I know you're younger, but you're going to be this too someday, so you have to kind of keep that in the front instead of the back, because someday that is going to be all of us, and anytime that we don't have to step over something on one foot, less time to fall. Less stairs means less chance of falling down and ending up at the bottom of the stairs, But I don't think that we as a society, it's all about what we like and our taste and what looks good. And, when and myself included, we're not thinking that we're going to be that person at 80 that can't get up the stairs and has a walker that's this wide with the doorway that's this wide,
Exactly.
So, even little things. So when people are talking, even family and friends just now, like, will ask my opinion. I'm like, well, if you're redoing your bathroom, I redid my parents' bathroom 5 years ago. My mom's like, we don't need all this. Yeah. I'm like, yet. I said, but when you need it, it's going to be too late because it's going to take too much time to fix it. So,
Right.
When you are redoing things, I always tell people, throw a grab bar up. Nowadays, they don't look like just the nursing home grab bars. They can be like this. They're silver, they're white, but they're safe. It's
Right.
not a towel bar. I can't tell how many people are patient. So I got a bar to grab, and I'm like, and they're like 85, and I'm holding my breath like, I bet it's the towel bar. And sure it is. It's that plastic bar that has the little things that just fits in, that you put an ounce of pressure. Not only is that going to snap, but you're going to end up, if you don't cut yourself, on the floor.
Right.
So, I try to work with families and patients, just trying to get some carryover that, hey, you have to think ahead, because usually by the time it's time to get something, it's too late. And we all, you're not going to build a house like you're 90, but nowadays they try to make, I noticed the newer houses, they're bigger doorways.
Yeah.
Things, they seem to be a little, builders seem to be a little more in tune with the fact that, we're not going to all live forever. We're not all going to be able to be running up and down the stairs, with spiral stairs and all this kind of stuff. So, the more we can do ahead of time, even if it looks like it's not the most aesthetically pleasing stuff,
Sure.
it's going to benefit in the end, because if you don't, then whether or not you're going to be able to stay in that house or that living arrangement comes into question. Because, if you can't get to the bathroom because your bathroom's upstairs and your bedroom's downstairs, when you're 80, what are you going to do? Like that's an important thing. And then if you can't, we could put a commode in your bedroom so you have one. But if no one changes it and you can't carry it so there's a lot of things that come into it that a lot of don't give a lot of thought to, as it's coming into play.
Yeah. Just as the financial impact too, like I'd rather do renovations when I'm not retired yet, living on a fixed income. Like I'd rather, pull some overtime or something to do a bathroom renovation now than,
makes sense.
Than just be like, I have to destroy this bathroom when I'm 80 and I don't want to do it.
Right.
So what are the top, what type of clients do you see the most now? Is it like just everyone, or do you still get a lot of like the knees and the hips? Like
it's really, it's everyone, kind of top to bottom. I think my youngest person I've ever seen was 9 months, and then the oldest was 104. So it goes anywhere in between there. We all see a lot of orthopedics. It kind of runs, I call it off season. Like holidays, it's a little lower for orthopedics because the doctors aren't operating, because they're going on vacation or they have the time off.
No one wants to have their hip done around Christmas.
Right. Yeah. Exactly. Although I have to say, I'm working Thanksgiving, and a patient that I had for a hip a few years ago already called me. She was getting hers done the day before Thanksgiving. I'm like, well, as luck would have it, I'm actually working on Thanksgiving, so I probably will see you. But
we'll shove a lot of family over to like help her out the next day too.
But we see patients from every type of diagnosis. I mean, and even with having quite a bit of experience on my own, sometimes just looking at the diagnosis and saying, "Oh my God, it's just PT only," and I'm saying, "Okay," because some of these, some of them could be intimidating. And sometimes I'm sure we all know, because we're all like, if what people look like on paper doesn't mean that's what they look like in person.
Exactly.
And sometimes you look at this paper and you're like, whew, okay, so I'm geared up for some kind of like big thing going on, and I go in and I'm like, wow, this patient's doing great. And then other times it just says, something kind of simple, straightforward, and I'm like, all right, and you go in and you're like,
holy moly,
oh my God, I'm going to be in here for 6 hours, because there's, there's so much more to it than what is just on the paper, so.
So when you're dealing with someone like with a knee or hip or a rotator cuff tear or what have you, like those are like the more common things that like I hear of, even though you do the whole spectrum. When you're doing physical therapy with them, like what's the physiology behind that? Are you strengthening the muscles around where they got the work, like so their system's stronger? Like
it really depends on Nancy, what the diagnosis is.
Okay.
Like typically with shoulders, we're not doing a lot of exercise with that, because most of the shoulders, especially if they're having a total shoulder done or reverse shoulder, some of the rotator cuff repairs or labral tears, the doctor wants that to be solid because of the nature of the joint, because it's only held in place by muscle.
Okay.
So the most exercises that they might be doing is pendulums, which is just using their body to swing and do some motion.
Okay.
They can do elbow motion, wrist motion, hand motions. So the shoulders seem to be the most restrictive as far as what we do. So someone might say, well, why are you in the house? Well, that then in turn goes to, are they dizzy? Are they walking okay? How's their balance? That in particular, when it's shoulder or upper extremity, occupational therapy gets involved, because can they shower? Can they get dressed? Are they able to cook? Can they brush their teeth, their hair? Can they put their shoes on? So as far as our role in the home, like as far as like a shoulder, I'm just as an example, it's more about living stuff than actual the exercise and the strengthening, because that type of diagnosis, it's usually a little further down the line. Now, when you turn it around and we kind of go more with where I am, a knee, we're hopping on that knee right away. We need to capture the range of motion. Like that knee has to bend. When you have a window of time that you want to get X amount of degrees, and you need to do that, because if you don't, then that might limit the patient, and then the doctor might have to do a manipulation where they go in and break, bend it for them.
Yeah.
So with the knee, you hop on it because of the nature, that's a hinge joint. So we want to get that range of motion. We want to get them moving. Of course, with the exercise, they're doing some strengthening, But again, going along with home care, can they get in and out of bed? Can they get in the shower? Can they go up and down their stairs? Can they get in their car, get out of their car? So that we're prepping them for outpatients, because we're usually in the house now for 2 weeks and then out, they're out to outpatients as far as therapy goes.
How do you know how far to push? Like if someone's like, oh, this really hurts and like whatever, like when do you call it? And like,
I'm not a fan of no pain, no gain. So I'm not one of those people. If I had a patient and they were really complaining about pain, or I really couldn't, we kind of were hitting a wall, my first thing would be calling the doctor and say, listen, I don't know if you need to see this patient or if something's going on, but I feel like we should be able to do more than we are, and their pain is getting in the way.
makes sense.
So typically, something like that, I would call the doctor, because there are things, unfortunately, that can happen.
Right.
That it's not all the time and it's not much, but sometimes things can happen. So I would pull the doctor in if I was feeling like I hit a wall. You know what I mean?
Yeah.
Sometimes it's as simple as saying, listen, I know it hurts now, but you're going to turn the corner. It's only been a few days. You got to hang in there, and then I'll review again. Are you doing this? Are you doing that? Have you tried this? Can you move this? How about you do this? And so let's regroup. So we try that again. And then since we see orthopedics the most out of the groups of patients, I'll be back in 2 days. So I'd like you to try this. See if that made a difference. You know what I mean? If that doesn't, then we're going to have to go into something else. So you got to be very pliable and trying a bunch of different things, and I think that now medical field's doing a much better pre stuff where they, the joints, and which, since we're talking about joints, they have to go to a class. And then, they usually have a home visit before their surgery where home care will go in and evaluate the house and make recommendations for equipment and moving this and doing that. So I think that there's been a lot more education so that people kind of know what they're getting into ahead of time. So on that sense, I think that's been a wonderful thing, which has kind of helped the whole, process of all of that. So I think that helps. Does it help every single person? No. But I think that the majority of people, definitely. And then the last one you asked me about, like with a hip replacement, that one, it's again, it's kind of like the shoulder. The hip's held in place by muscle. So we're not like hopping on it to get a lot of range of motion, and the doctors like that to tighten a little bit. So, they might be, depending on which approach they have, there's certain restrictions that go with that. So it's a lot of education, and, you got to be careful you don't do this, but you can do that. And, we want you to be moving, but you want to be careful when you're doing this. And are you sitting in a high enough surface? So, each one stands alone, and there's different expectations from each one. But again, I feel like especially on the orthopedic side, there's been a lot more pre-education for patients, so that they can understand what they're getting into, not just, watching a video or, I always tell patients, don't watch your replacement before you get it. If you want to watch it after, pull up the video on YouTube and watch it after, but don't watch it ahead of time.
I'm on that boat.
Squeamish. You know what I mean? Just wait. If you want to see it afterwards, you go ahead, but don't do it ahead of time.
Right. Right. Of course. We talked about goals a little bit. When you're setting goals with the patient, what happens if they have like this idealistic goal? Like
unrealistic.
Yeah.
Yeah.
Yeah. Unrealistic. Idealistic, unrealistic. Unrealistic's probably better. Yeah. Unrealistic. Like, they're 75 and they're like, I want to look like J-Lo in like 2 weeks, or like whatever, like they just want to get back to a level that might be a little far reaching. Like, how do you talk through that? How do you set realistic goals with patients?
Usually when I see someone first, I in my mind, I've got what I think that they should be able to do. But I'm very interested. One of my questions off the bat is, what would you like to get back to doing that you can't do now? And we start that way. If again, to your point, if it's a 75-year-old person, and I'm just going to be a little outrageous, and they haven't run in 15 years, and they say to me, I want to go back to running a marathon. Well, that's like a hard stop. I'm like, I think that's a little overshoot. I don't think that that's something that I kind of pose it, Nancy, like, I don't think that's something you're going to achieve with me. You know what I mean? So we need to work on something that I can work with you and do with you, and that you and I can, as a team, can achieve together. So typically when people come out with some of the little bit more far-fetched goals or outrageous goals. I tell them, it doesn't mean that I don't think you're going to meet this goal, but my time in the home is very limited. I'm not there for 6, 7, 8 months.
Yeah.
Some of the patients have goals that really, I think they could get to in 6, 7 months, but it's not going to be when I'm there. So I tend to tell them, let's start a little smaller, because I'm a believer in like the small picture, and then we get to the big picture. So plus it builds positive reinforcement by doing something that's small. So you can say, hey, look, you couldn't do this on day 1, but now after 4 weeks, we can do this.
Right.
So I always try to pose my goals and try to pull them into that on stuff that when it comes time to do a reassessment of them, that I can say, hey, this was day 1, this is now, see how much progress you've made. So you are going in the right direction. And with the way healthcare is, we're not in the house as long as we used to be 3, 4, 5, 6 years ago. So we have to try to keep our goals a little more targeted for stuff that we can achieve. And I also, will say to patients, this is now. I said, so you've kind of hit your baseline for now. You're safe. This is where you are. It may not be exactly what you want to be doing, but if you keep up with stuff, you're going to get there. And with home care, it's not one-stop shopping. It's not like you can only go in one time a year.
Yeah.
So I'll tell patients, I said, you've got to try this on your own. You start to fall off a little bit, then we can come back again, do another refresher. And maybe during that refresher, we get you a little further along than you are now. So,
It's like
it's not like it's just, and there are some patients, of course, with certain diagnoses, some of your higher neurological ones, the Parkinson's and all that, you're going to see them again, because that's just the nature of that type of thing.
Exactly.
So it's not goodbye, I'll say to them. I say, see you later, because I know I'm going to see them again. But, I say, listen, I expect you to work while I'm not here.
Right.
Because if I come back and you haven't been working, then we're going to have to take the time I come back to get back to your baseline when I left. How about we go from your baseline when I left and we try to go a little further?
Exactly.
So if you can kind of get them to think like that, and then there's some patients that you're never going to get them to buy into it. If they're not on Mount Everest, then they're not happy. So you do the best you can with those, and you get them as far along as you can, and you try to encourage them to keep working.
Yeah.
And, but that's with everything, I think. So
Of
I think when we start smaller and, because they pay your patients, we all have, delusions of grandeur. But if we can kind of cut the goals back to something that we can
Delusions of grandeur.
that I can help you meet, so that they feel like,
A lot of those delusions of grandeur.
we all do, Nance, not just you. So, but it's sometimes it's with the personality and stuff like that. But, if you can get them to trust you, and it's really, you're in their house, so you're on their turf. So it's really, you got to get,
Yeah, there's a level of respect.
Somebody honestly says to me, I want to do this, and I'm looking at them like, I think that's really great that that's what you want to do, but I'm being honest with you, and I'd be honest with my own family. I said, I don't think that we're going to get there. I think you have to look a little bit differently.
Right.
How about like this instead of that?
Right.
You're still doing it.
Short-term and long-term goals.
And a perfect example for you, Nancy, everybody, I don't want my walker anymore. Well, why not? It makes me old. I don't want a walker. Yeah, but with the walker, you can go out with your daughter, you go to the restaurant, right? Well, yeah, okay. So if I take the walker away, you're going to be able to do that? Well, maybe. I said, well, how are you going to do that? And maybe I'll hold on to somebody. I'm like, who? Well, maybe my daughter. I'm like, but what if she falls? What if you trip her up? And then you start getting them to think.
Yeah.
You know what? Who cares that you're using a walker? You're doing what you want to do. So it doesn't matter that you've got the walker. You're getting to the restaurant. You're going to the store. Right. You're going shopping. So if you are doing what you want to be able to do, who cares that you have the walker?
That's a point of big resistance. Yes. I mean, either my mother-in-law is 90, and she had a tough time even thinking about a cane. Yeah. And she just outright waved me away when I was talking to her about a walker. It's very difficult.
There's almost a sense of embarrassment.
Yeah, it is.
I would say,
and but that's why I try to turn it around and be like, but you're doing what you want to be able to do safely.
Right.
Exactly. Well, if you don't want your walker in your house, what if you fall and you can't come home?
And then if you're falling, it could end up with another hospitalization, maybe even a nursing home stay, or maybe a permanent nursing.
That's what I mean. So then you're not going to be home. So if walker keeps you home,
and that's
it's a no-brainer. I'll say it right to him. No-brainer. Who cares? You know what I mean? It's so trying to tie it to, it's not that I'm threatening them, but it's just I'm trying to present that if you're able to get out and your family can get you out and you're safe that way, no, we weren't meant to have walkers, when we were born, but if that's how you can be safe, or using the little electric cart in the store because you've got your oxygen tank. Who cares? You're shopping. Unless you don't want to shop. But if you want to shop, that's how you shop.
Yeah.
You know, so sometimes they're not flexible, and you kind of have to pose it that, you know, you got to be a little flexible. It's not give or take. It's give and take together.
Yep.
Yeah. Someone in the family just had some major back surgery done. And they bedazzled her walker that she needed to use, like painted it hot pink, like studded it, and like put headlights on it. Like this thing was like the ultimate Gen X walker, you know? So, I mean, you can try to make things fun too, I guess.
And they sell some of the coolest canes now. I don't know if you've seen it, like in CVS. I mean, they've got flowers to, you know, to stripes to, you know, all kinds of stuff like that. They can be very fun. You know, it doesn't have to be just that silver looking cane that, you know, your great grandmother had or something like that, you know, so.
It's been at the back of the closet.
Yeah.
So before we summarize, I guess I have one other topic that I want to approach with you. And I'm, you know, recalling this from when my mom was alive. When you go to buy furniture, when you're buying chairs, like their comfy chair, their recliner, a bed, like I remember we just had to rethink a lot of things with my mom, because even her bed, like she was like stepping on something to get into the bed. We had to buy like one of those little like box springs and then have a mattress. So when you're with your mom or your dad and you're buying furniture, or your husband and you're buying furniture, like what are the good heights that you're looking for when you're buying a chair, like a recliner chair or whatever? Are you looking for a more firm chair, or that softer, comfy chairs, harder to get out of?
Any of us, young, old, us, the easiest chairs or anything to get out of is if you can keep your hips a little above your knees. So some of these real comfy, you know, you kind of fall into chairs that your knees are like this and your hips are below. Not only do you have to meet the mechanical advantage of getting to the 90, then you have to be able to stand up.
Right.
So some of those real softy, you know, big fluffy recliners where they all get lost in and they look like they're just covered in
like marshmallow.
You know, I mean, a lot of people had those like from years ago, because that was a big thing like years ago. Those are so comfy and all this kind of stuff. And of course, especially with older people, now you've got all those pillows and then you got this big divot because it's been there for like 30 years. You know, no one wants to get rid of it. But when you're looking for stuff, as far as, you know, for all of us, again, planning ahead, the safety, you know, you want something that's a little firmer under your bum, because that gives you a little bit of a brace. And if you can keep your knees at least even or a little bit above, it makes it just easier for all of us to get off the surface. I don't know what it is, but it seems like people, all ages, want beds that are like you're 5 stories high, you know, and I'm not sure if that's just like where society is, or it's just, you know, people, I don't know what it is, but they have really high beds, you know, and so that makes it nobody thinks about that until, again, something happens, and then they can't get in their bed. They can't get forward. They can't get backward. You know, and sometimes what we've done as far as, you know, in therapy and at home, we've had families buy, if you can picture the steps that they use for step aerobics, the toppers that go on, because those don't slide. So because they're about this thick and they are all one level, you know, so it's flat. So that, you know, that's one suggestion that you could use, because it's not going to move.
Right.
You know, that's about like a $20 investment from Walmart. When you're getting into bed, if you can get your bum at least on the bed, you know what I mean? Like, you're not like, it's not this part of it, but if you can get your cheeks on, then you use your hands to kind of slide yourself back, like us, you know, like of our age, like that.
Yeah.
Or if the bed has a lip at the bottom, which people don't buy them anymore, like the base that goes down, you know, there's a wooden thing. Some of the older beds, which is nice, I can have my older people just put their foot on that, and that at least gives them that little bit of help to get their bum up on the bed.
Yeah.
So they can do that. But I don't know what it is, but we as a society seem to be like these high beds.
Yeah.
You know, and even some of the older people, they go in forward, and I'm like, hey,
Yeah.
You know, it's like they're diving in a swimming pool. You know, it's like
She
What
just
is-
described me like this last
Is that right?
Yeah, we have one of those old Ethan Allen beds with like the double
You
mat.
dive onto it.
I'm thinking of getting my little step stool that I use for my closet. Like, I'm like,
Yeah.
how the hell do I get on this bed? And it's like,
careful because you can
dive
fall
in.
off the steps too.
yeah, I'm sure.
So you got to be,
Especially as you're aging. You know,
I am
Nancy,
telling
be
you.
Very careful, Dan.
I'm telling you that you know me.
you know, when people are now, it's like trying to replace recliners and stuff like that, especially for their loved ones, because they've come down so much too in price.
Right.
I'm always like advising get an electric recliner, and the family's like, oh, well, I want them to still stand up on their own. I'm like, they will, but the days that they're not having a good day,
Right.
or the day that they're
You talking about the
struggling-
lift one?
Yeah,
Yeah, the lift
the
one.
electric lift ones.
Okay.
The days that they're not doing
I
well,
have one of those, right?
those are.
Not yet.
Those are those like that they make a big difference. You know, everybody says, "Oh, I'm going to get rocket ported up." No, because you can buy them as far, you know, all the bells and whistles, or just I bought one for my dad, and it's just got 2 buttons up and down.
And it goes slow enough that they
It
can.
goes so slow. I mean, and I get in it every other day to make sure it's working right.
Yeah.
And it's only got 2 buttons for him, so he's got 50-50 chance of getting the right button. So if he's not going in the right direction once, he just has to hit the other button. Whereas some of them, like I said, have 12 buttons because they vibrate, they heat, they shake, they do what, you know what I mean? They do all that. They massage, yes. But you know, they've come way down. And when people are looking to replace something for a loved one because they were in the nursing home or they're struggling at home, I think that they're a good idea. You know, some people will say no. I think they're a good idea because I think the pros outweigh. Yes, there are cons, but I think the pros. If you're gonna buy it, if you're looking to replace a new one, that gives you many options. And the other thing is, you don't have to use a controller.
Yeah.
If they don't want to, they can sit like this, but they have it if you need it. And then my point in getting it, even for my dad, is my mom can't lift my dad. So if he can't get out of the chair, she needs some help.
Right.
He's 6 feet, so she can use the controller to get him to his feet. So
Nice.
you know, there's a couple of reasons that go with it.
Right. I think I'm going to ask you if you can just share a patient's story with us that's really affected you and your career.
Something that really benefited the patient you can think of.
Okay, well, I do have one that is very near and dear to me. It's from about 13 years ago.
Okay.
It was a patient that she wasn't diagnosed when I started with her, but when we were in the process, I did get to see her for over a year, which was unusual, but I was in and out of there. She got diagnosed with ALS while I was in there, and it went very progressive, like very quick, as that often does. And I was very close with the family because I worked with getting equipment, and things changed so fast. And one of the best things that happened towards the end of her, life was that I was able to help her go on a cruise. So we got her all the equipment, and we got her bed, we got her everything that she needed so she could go to this cruise and go to a beach. That was like her dying wish. So that was one of the best things that I did. And when she came back from it, she went on her cruise, and I actually was going to Disney with my daughter. So we were talking about our vacations. And so she came back and she gave me an ornament full of pink sand that I treasure, that I have in a box that's not even with Christmas stuff, but I keep it because it's something that I just, felt so touched. And I gave her a mug with the Wicked Queen on it because that was her favorite character from Disney. And her husband actually buried her with it because it was very special to her.
Right.
So, but the best part to my story, other than the fact that I feel like I truly made a difference with her life right up to the end, which is something that, you'd like to think you make a difference with everybody, but sometimes there's a few things that are different. Her husband sends me a card every year at Christmas time. So for the last 13 years, I get a card from him wishing me a Merry Christmas, that he's thinking of me and thanking me for all I did.
That's great.
After all these years. And I'll send him one back. So we've kept in touch. He's in Florida now. But every year I look forward to getting that card because I know that, obviously I made a difference for him. And, I did all I could for him and his wife before, she passed away. So that's something that I'll always treasure. And remember.
That's great.
So I'm very blessed that I had that experience.
Thank you for sharing that.
Great story of how you really impacted on someone with your, with what you do in your profession. That's wonderful. Is there one message you want to leave the audience with as we come to a close?
Don't be afraid of physical therapists. Also, kind of tying up with everything that we've talked about, just be thinking ahead, make sure that everybody's taking care of themselves. We're all going to get old. We all get injured. There's a lot to be said for taking care of yourself and, maintenance and whatnot. But don't be afraid to look into things, and, things don't get better on their own. So as far as whether it's seeing the doctor, asking the doctor for a therapist, a nurse, sometimes the earlier we get to things, the less of a big deal things become.
Sure.
So whether it's home care, outpatients, or any kind of stuff like that, I encourage people, not to wait. Sometimes you need a little help, and we're always happy to help. So
great. That's great.
Yeah, thank you so much for being on our show. It was really interesting. I learned a lot because I honestly wasn't aware of everything that physical therapists did in the home as far as, being kind of more the eyes and the ears for what's going on in the home. I mean, I thought of it more in a very focused physical therapy role. So that was very interesting for me to learn. So thank you very much. I'm sure the audience appreciated it too. I want to also thank everyone for listening to our show. And if you'd like to become a sponsor, contact us, please, at 617-775-3737. Special thanks to Ron Gamache for our intro music, Primacare, your trusted medical providers in southeastern New England, and the BioSkills of Northeast for producing our show, and available to produce your show by calling 774-301-8811. BayCoast Bank, just right for all of your financial needs. Visit baycoast.bank or call 508-678-7641 to learn more. And Duncan Hearing Healthcare you can trust, with sites in Fall River, Dartmouth, Falmouth, and Centerville. For more information, visit their website, duncanhearing.com. And once again, thank you so much for being on our show.
Thank you very much for having me. I appreciate it. Thank you.
Bye now.